Good morning or afternoon or evening, wherever you may be. We have a lot of people joining us today to hear from Dr. Orly Leiva, who is Advanced Heart Failure and Transplantation Fellow at the University of Chicago Medical Center, my old stomping ground in Chicago. And oops, it doesn't look like huh. Oh, yeah. Is my audio on? Sorry, bear with me. And so we're going to hear a lot today from Dr. Leiva, what he is doing in his lab and some of the things that he has discovered in cardiac health with MPN patients. And then we will go through a list of your questions, and please send them along as you listen. Please welcome Dr. Leiva.
Great. Thanks for having me. I'm going to share my slides. And let me know if you see them.
Yes, we do.
Perfect. Yeah, so as Anne mentioned, my name is Orly Leiva. I'm a current advanced heart failure and transplantation and pulmonary hypertension fellow at the University of Chicago. I have a particular interest in research interest in cardio-oncology, particularly in peripheral neoplasms. I've been doing research in this realm since I was a medical student for the past 12 years or so. So I'm excited to kind of just talk to you guys a little bit about MPNs and cardiovascular health. I think it's something that is very important and not very it's still kind of in its infancy with regards to the research and the data. So I have no disclosures, just that I'm a cardiologist, not a hematologist, and this is educational, not to be taken for medical advice. So if there's any other, particular questions about your particular care, please talk to your doctors. But I hope this is informative and will kind of inform questions to ask to your physicians and get you to advocate for your health and improve your health. I'm giving this talk to a group of patients, a group of people who I assume are very well versed, but in case anyone's joining that's not very well familiarized with the myeloproliferative neoplasms, there are a group of disorders with increased caused by increased blood cell production. It's a clonal hematopoietic stem cell disorder. And this includes the three major types are polycythemia vera, essential thrombocythemia, and primary myelofibrosis. So we're going to be talking mainly about the Philadelphia chromosome negative MPNs and not CML. The median age of diagnosis of these disorders are in middle age, about 55 years for ET, PV 64, and PMF is 63. But obviously, this is just the median, so a lot of patients are diagnosed younger or older. And one of the things that the hematologist always kind of worry about and monitor patients for is the risk of hematologic progression. That's either progression to more aggressive forms of the disorder, such as secondary myelofibrosis, blast phase MPNs, or acute leukemia. But also we have to pay in mind that patients with MPN are also at risk of cardiovascular disease. And I think that's something that's very well known within the hematology community. A lot of the treatments are aimed towards reducing the cardiovascular risk. But I hope that my presentation will shed light that, in addition to the thrombotic risk, blood clots and bleeding that patients with MPN have, there are also non-thrombotic parts of cardiovascular disease that I think have recently, and the work that we've done in research have kind of shed a little bit of light on. So not to impress, this too much, but, cardiovascular disease is one of the leading causes of death in MPNs, particularly those with ET or PV. As you can see, cardiovascular and cerebrovascular, which, I think are the same thing, or can be grouped together, are the most common, if you group them together, the most common cause of death in ET, PV. And although hematologic malignancy is the most common in PMF, cardiovascular disease is a close second. So I think this is very important, and I think this is where we have lots of room to improve and lots of things that we can do as both physicians and patients to kind of help reduce that risk, which is a big part of MPNs. So this is from a review that we published back in 2022 in the Journal of American College of Cardiology, Cardio-Oncology. If you're interested in reading that review, it's a pretty comprehensive review of what at that point in time, the current understanding of cardiovascular disease and MPNs. And I just want to essentially point attention to, obviously, there is the thrombotic aspect of MPNs that is worrisome to the hematologist. That includes atherosclerosis and arterial thrombosis, as well as venous thrombosis. But there's also a subset of cardiovascular disease that is not necessarily mediated by thrombotic risk, and it might be independent of thrombotic risk, and that is pulmonary hypertension and congestive heart failure, which comes in many different flavors. And as our work has kind of shed light on, heart failure and pulmonary hypertension are more common among patients with MPN than previously thought. And the phenotypes of the pulmonary hypertension and heart failure seem to be a little bit different than the general population, meaning that there's a different underlying pathophysiology leading to congestive heart failure and pulmonary hypertension in these patients. So the most common cardiovascular kind of complications that everyone thinks about is thrombosis. So that's blood clots in MPNs. And then so I'll break it down to arterial and venous. So arterial thromboses happen in arteries, which are the blood vessels that carry oxygenated blood away from the heart. And those can include something called myocardial infarction, which is the fancy term for heart attack, ischemic stroke, and then also peripheral and arterial thromboembolism. Essentially, it just means clot that breaks off and goes to different organs and kind of can starve organs of blood, and also can go to the extremities and starve the extremities of blood as well. The other is venous thrombosis. So this happens in the lower pressure blood vessels that generally take blood from the body to the heart. And that includes deep venous thrombosis, pulmonary embolism. That's when the blood clot goes to the lungs. And then particularly in patients with MPN, splanchnic venous thrombosis. That means venous thrombosis in the vessels of the gut, which is otherwise pretty rare, but in MPNs is more common than the general population, can also occur. And so there was this meta-analysis published in 2019 of 29 studies that included 13,000 patients, that the prevalence of any thrombosis is about 1 in 5. Particularly arterial thrombosis is a little less than 1 in 5, and venous thrombosis is about 6.2%. So that is, something to keep in mind of, and obviously something that hematologists and cardiologists have been aware of for quite a while. And thrombotic risk tends to be higher in patients with PV and ET, not so much PMF, although there is, there's other studies shown that PMF is also associated with thrombosis, just a little bit harder because to define, because patients with myelofibrosis also tend to have low platelets, which predispose to bleeding. So there's a lot of things that are done to kind of mitigate this thrombotic risk in MPN patients. Some of the things that are included in the NCCN guidelines, and your hematologists are very well versed. For polycythemia vera, aspirin has been shown in randomized trials to reduce cardiovascular risk, particularly thrombosis and stroke. As well as kind of maintaining hematocrit counts less than 45%, either by phlebotomy or medications like hydroxyurea or Jakafi. As far as patients with ET, it's a little bit more complicated, and I'll leave it to the hematologist to really decide which patients would benefit from aspirin. But typically, it's those with intermediate high risk essential thrombocythemia, particularly those with prior cardiovascular disease or risk factors. And there is some studies suggesting that maybe aspirin twice a day might be better in these patients because the platelets just turn over really quickly. So aspirin works by inhibiting a receptor in the platelets. So the more new platelets are made, the less effective aspirin is. So there is some evidence that suggests that if you have ET, maybe taking a baby aspirin twice a day is a little bit better than once a day. But again, you should talk to your hematologist, cardiologist about it. And as with any rare disease, it's very hard to do these kind of randomized control trials with regards to primary prevention. But statins, which include brand names like Lipitor or Crestor, atorvastatin or rosuvastatin, are kind of common medications used to lower cholesterol and reduce the risk of stroke and heart attacks in the general population. Within the MPN population in specific, The data is a little less limited, but there have been some retrospective studies, particularly that by Podolstev, published in 2023, which used a large Medicare-linked cohort that showed that statins may actually reduce all-cause mortality in patients with MPN. Again, these are just preliminary data, and we need to really do more studies to kind of definitively to say that they do, but it's something to kind of consider and talk to your doctor about. So I'll move on to the non-thrombotic cardiovascular disease. So these include congestive heart failure, so congestive heart failure comes in two flavors. There's with preserved ejection fraction or reduced. Essentially, the way I think of it is preserved ejection fraction means the heart is stiff. And so when the heart is stiff, it can't fill with blood. The blood backs up to the rest of the body, and then kind of fluid backs up. And that's why you get congestive heart failure symptoms such as shortness of breath and swelling of the extremities. And then you have systolic dysfunction or congestive heart failure with reduced ejection fraction. Essentially, that means that the heart muscle is weak and can't pump blood forward, and also it backs up as well. So I didn't show the data here, but in prior studies that we published, it seems that in the general population, when you look at the types of heart failure that occur, either reduced or preserved ejection fraction, tends to be about a 50-50 split in the general population. In patients with MPNs, it tends to be a lot more preserved ejection fraction. And there is a subset of the preserved ejection fraction called high output heart failure that is known to be more common in MPNs. But also there's kind of inflammation, and there have been mouse studies of mice that have the mutations that are found in MPNs that have shown that those mice have stiffer hearts, and more what we call adverse remodeling of the heart, meaning that when there's an insult to the heart, they tend to form more scar tissue in the heart, making it less able to pump and more stiff. Pulmonary hypertension. So it kind of can go related with heart failure, but it's also kind of its own thing. Much like your systemic blood pressure, when you say you have hypertension or high blood pressure in your body, the lungs can have high blood pressure, and that could be due to a lot of different things. Sometimes heart failure can cause high blood pressure in the lungs, but then especially in patients with MPNs, you can have high blood pressure in the lungs that's out of proportion to what's going on in the left side of the heart. And we will be presenting some of our newer data at the American Society of Hematology, suggesting that there is a link between pulmonary hypertension, particularly in those patients that have a normal heart, and progression of their MPNs to more aggressive forms. So this is something that's kind of new on the cutting edge and still needs to be kind of validated in more prospective studies. But I'm excited to share that data when we publish it in December at ASH. And then other things as arrhythmia. So atrial fibrillation is a very common, so it's the most common arrhythmia, and inflammation due to the mutations in JAK2 and also other mutations associated with MPNs can induce inflammation in the heart, and also heart failure itself can cause stretching of the upper chambers of the heart called atria, and that can lead to something called atrial fibrillation, which predisposes patients to both heart failure and things like stroke. So these are kind of things that are known that our MPN patients are a slightly higher risk than the general population, and things to kind of be mindful of going forward. So this is a very busy slide, but it's from our most recent review in 2024, and this is just summarizes all the most recent data from our group and also from other groups about cardiovascular diseases in mild peripheral neoplasms. And so we looked at atherosclerosis, which is myocardial infarction, and ischemic stroke. And our studies have shown that among patients who get admitted for a heart attack, those with mild peripheral neoplasms, those with MPNs, actually have the same mortality in the same hospitalization. So, for example, we actually showed lower mortality of patients with MPNs, so tend to do better in the first hospitalization after a heart attack. But in another study, we showed that despite the better survival in the short term, there is a higher risk of readmissions for either another heart attack or heart failure. So that's something that we need to kind of keep in mind of. Patients with atrial fibrillation and mild peripheral neoplasms have a higher risk of all-cause readmissions, and patients with heart failure have a higher risk of readmissions for heart failure or cardiovascular causes compared to patients without MPNs. And then this pulmonary hypertension as well, there's increased risk of both a major adverse cardiovascular events as well as hematologic progression. So lots of things, and essentially just highlights that there is lots of room for improvement in managing in patients. So the next slides are just going to be general tips of how to optimize cardiovascular disease. And these are tips that are kind of, I borrowed a lot of these slides from Dr. Feldman, who's the chief of cardio-oncology at Cornell, is one of my close colleagues, and also things that we generally recommend to all patients, but I think particularly with MPN patients who might be at higher risk of cardiovascular disease is something that might be a little bit more important. So it's important to kind of have a multidisciplinary approach to this. So MPNs is we think of a blood disorder, but the blood courses through the entire body. So I really do think that MPNs is more of a overall body disorder. And so I think important collaboration between your primary care physician, your hematologist, and maybe a cardiologist, kind of to tackle all the different aspects of the disease is the best way forward. Like what they say, teamwork makes the dream work. I think that's very true in medicine as well. And so there's this new field in cardiology called cardio-oncology, which kind of focuses cardiology on the cardiovascular care of patients with malignancy, either mitigating the treatment treatment toxicities on the heart, or also cancer itself that can cause toxicity, such as like an MPN. And so the current guidelines do not take into account the history of MPNs, which is a current subject of current research, and that's kind of what I'm kind of focused on is seeing exactly what the needs are in these patient populations. But the recommendations of cardiovascular disease kind of apply to everyone. So so this is from Dr. Feldman's slide. So I like to think of the ABCDEs of cardiovascular health. So I'll take them by kind of by letter. So A is awareness, and also aspirin. And so do you just be someone who knows their numbers, knows their blood pressure, is aware that by having MPNs you may be at higher risk of cardiovascular disease, and that aspirin might help. So I think having a discussion with your hematologist is just being aware and more conscious of your risks is a great place to start. The other is blood pressure. So B is blood pressure. So, in general guidelines, blood pressure goals should be around 130/80. And just keep in mind that, there's often this thing called white coat hypertension when, for whatever reason, doctors make people a little anxious and the blood pressure can go up a little bit, or maybe you're rushing to go from parking or the train stop to the doctor's appointment. So the office visit blood pressure is usually going to be a little higher than when you run at home. But that being said, having a home blood pressure cuff is super important. It's very useful. When you take your blood pressure in the morning, or as soon as you get up, give yourself 5 minutes to kind of meditate, relax, then take your blood pressure is usually the most reliable. And if you have high blood pressure or are tending towards high blood pressure, there's a lot of things you can do on your own, such as adhering to a low salt, something called DASH diet, or increase exercise, decrease alcohol intake. If you have a tendency to snore, your partner says you snore, talk to your doctor. Obstructive sleep apnea is a common condition, especially among patients who are older, and can predispose you to high blood pressure. And if your numbers are not at goal, you might want to consider medications, because there have been many studies, particularly in the general population, that controlling the blood pressure improves mortality in the long term. The other thing to see is cholesterol in cigarettes. So cigarettes goes without saying, smoking increases your risk of heart attacks, and for anyone, and in particular in patients with MPN who are already at higher risk. So smoking is a big no-no. So work with your physician if you smoke, and try to, cut that down as you can. The other C is cholesterol. So generally for patients who have never had a heart attack or have any source of atherosclerosis, we say an LDL goal of 100, less than 100 is good. There is evidence, and the European guidelines kind of are a little bit more aggressive with how low the cholesterol, but the general consensus is the lower the LDL, the better. And there is really no lower limit of LDL that is unsafe. So we really do think the lower is the better. But with regards to the MPNs, that exact goal is unknown. And so we just kind of generally adhere to the general guidelines. So less than 100. And there's dietary things you can do to lower your LDL. Obviously, cut back on the red meats and fatty foods, the sugars, and increase your vegetables. But also, a lot of LDL, bad cholesterol, is hereditary. So as much as you can do on your own, sometimes your genes work against you, and medications might be necessary. So this is something to talk to your doctor about, particularly patients with MPN, where there is at least some evidence that cholesterol reduction medications might reduce the risk of death. The other D is diabetes and diet. So again, know your numbers. You generally want a hemoglobin A1C of less than 6.5%. And again, diet is very important. So the Mediterranean diet is something that it's very, in the literature has been shown to reduce heart disease. And what I tell, children or young adults is like, you want to eat a rainbow for your meal. So you want different colors of vegetables and meats. Try to lower the red meats, but have more like fish, nuts, things of that, kind of make your bowl more colorful naturally, not with artificial food coloring. And then E is exercise. So, the goal is 150 minutes per week, and it could just be as simple as, instead of, so I, obviously live in Chicago. There's a lot of people who live in smaller cities where they drive all the time. But if you live in a city, maybe walking that extra block instead of taking the bus, or maybe when you're inside this inside a building, walking the flight of stairs up to your office instead of taking elevators. Just little things just add up during the week. So whatever you can to get moving is important. And particularly if you do have a history of heart failure or had a recent heart attack within the last year, something to discuss your doctor about is referral to cardiac rehabilitation, which is a supervised exercise program that has been shown to reduce more death in patients with recent heart failure or heart attacks. So I think my take-home points are, patients with MPN are at increased risk of cardiovascular disease. And I think working closely with your hematologist and cardiologist to reduce these risks is very important. And patients with MPN should be empowered to decrease their risk of cardiovascular disease by adhering to the ABCDEs. And I want to thank you. If you have any questions, I'm happy to answer them, or there's my email as well.
We have a ton of questions. That was really wonderful. Thank you. And I am a person who has a genetic or familial high cholesterol. I tried everything on my own and it was still at 300. And so I have to inject Repatha because I can't take a statin. And I share that only because there are genetic predispositions to some of, some heart diseases and to cholesterol. One of the questions, I have many, but one question is, in all these studies, because we know in the United States, women die from heart disease predominantly. And so were in any of those studies in MPN patients, was there any separation of female and male in assessing?
Yeah, that's a fantastic question. At least in the studies that we've done and that I've read, there really wasn't much of a difference between men and women. However, I think that is something that's understudied, and I know that some of my colleagues, such as Dr. Joan Howe at Brigham and Women's, has done work in the gender disparity. So I think there's a lot to be done in that realm.
Yeah. And so should one be concerned if this person is a female patient with a hematocrit of 44 and had atherosclerosis on an abdominal ultrasound? When should she go to an ER with chest pain?
Yeah, so that's a great question. So once, particularly in cardiology, we talk about primary and secondary prevention. Primary prevention essentially means you're trying to prevent the disease from happening. In this context, the disease is atherosclerosis. And so once you have evidence that you have atherosclerosis, such or plaque in an abdominal ultrasound, now you kind of move to a higher risk secondary prevention kind of cohort. So in those patients, those are the people who generally if I saw in clinic, I would put them on a statin because it's no longer primary prevention. Now you have evidence that you have atherosclerosis. So a statin, discuss maybe aspirin, and that those are the patients that are at slightly higher risk of having an event. I think when in terms of chest pain, it's just it's a complicated question. I think in short, I think better be safe than sorry, especially if you're a woman. Women tend to present more atypical when it comes to heart attacks and things like that. They might not have, overt chest pain. They might be even indigestion or chest discomfort, chest pressure. So if anything lasts more than 5 minutes and it's like just unusual and you're just concerned, I would just get that checked out just to be safe. Especially if it's something that comes on with exercise. And so I think just I would just err on the side of trust your body, listen to your body, and just be err on the safe side.
This person had rheumatic fever when they were a child, which affected their heart. They had a mitral valve repair in 2009 and then was diagnosed with ET this past summer. They're taking 500 milligrams of hydroxyurea every day. Does this combination increase their risk of heart attack and stroke more than it did with just ET?
Yeah, that's a fantastic question. And everyone with rheumatic heart disease, especially with the mitral, repair, and there's always a risk of atrial fibrillation, of atrial arrhythmias, and stroke. I don't think that there's been studies looking at these things, particularly this combination. So I would probably just err on the side of what we usually do for these patients with rheumatic, prior rheumatic heart disease. I'm not sure if they have atrial fibrillation or anything, but monitoring and if detected, kind of managing that per the guidelines and just adhering to the rest of the heart healthy kind of advice. But that is something that is also an area that's not very well investigated.
Right. It really isn't. I've been in the space for a long time, over 20 years, and it's just now, more and more people. Ellen Ritchie at Weill Cornell did a great study on cardiac health and MPNs, and she speaks at a lot of our events. But I mean, this was very informative, and we're happy that more people are getting involved. Is apo-b a test I should ask my hematologist to do?
Yeah, apo-b is interesting. I think it's something you should ask your cardiologist to order. As a cardiologist myself, it's not something I order very frequently. I'm more in just testing LDL, but in certain patients, especially with those with a family history or early or accelerated atherosclerosis, I don't think it's an unreasonable thing to add. Another test is that consider, especially if you have a family history of heart disease, like for example, if you have uncles, aunts, cousins that have had heart attacks early or young in the 40s or 50s, to have your cardiologist check something called Lp(a), which is kind of like a newer thing. Is actually becoming more ingrained in the guidelines. There's actually more clinical trials ongoing right now on agents to reduce that, and there is a lot of evidence that Lp(a) in the independently of LDL is actually also associated with cardiovascular disease. And again, within MPN patients, that's it's unknown, but this is just generally for the general population. Yeah.
So, would you recommend an initial cardiac review, perhaps a stress test, ECG, EKG, peripheral artery test, etc.? It seems to me that this would be terrific information, which in which to establish a baseline.
Yeah, that's a fantastic question. I think because we're kind of when you add the MPN kind of in the mix, it makes it a little bit more nebulous because a lot of these studies are done in the absence of MPN. So what I'm going to be recommending here is just in the absence of evidence, just adhering to the general guidance. So generally, a stress test, EKG. I think an EKG is an okay idea, especially if the patient's on the older side, like above 60, or has some other like risk factors to get an EKG, just to make sure, just get a baseline. The terms of stress testing is where it gets a little bit more nuanced, and I think you can ask different cardiologists their opinion, and the guidelines make it so that it is kind of the art of medicine as well as the science of medicine. So when we order a stress test, we really, we want to ask a question when we order the stress test. And a lot of times that question is, the stress test is to find evidence of blockages in the heart arteries. Especially now with the newer evidence with the larger, randomized control trials, including something called the ischemia trial, which really looked at patients who had a positive stress test and had evidence of blockage, but were otherwise, asymptomatic or weren't, having any symptoms. That showed that, if you stent those patients or if you do bypass on those patients, you really don't increase life expectancy. Like it was very, surprising, but it is something that, it doesn't add life expectancy. What it does do is reduce symptoms. But this excludes patients that had really high risk disease, like, blockages in very, very large arteries. Those patients were excluded. So my general, approach to this question is, I think it's always good to get a baseline, especially if the patient's concerned. I don't think that there's a harm of, putting the patient on a treadmill, seeing how far they can go. If they can go a long time on a treadmill with the Bruce protocol, which is really hard, then I'm reassured that that they're fine. They don't need any more testing. And if there is, if there's something that's slightly abnormal, maybe having a discussion with the patient, if they're not really having that many symptoms, they're not really, it's not really limiting their life. Going down the cascade of more testing, which means sometimes more procedures, which has the risk. At some point, there's like a risk benefit discussion that needs to be had. But that's always good information, because, for example, if there is a blockage, but maybe it's not severe enough to warrant an invasive evaluation, maybe that will prompt the cardiologist to just be more aggressive with lowering the LDL goal or managing the other things. So it's not the most black and white answer, but it's
okay. How could you? I mean, it's impossible
Yeah.
to answer it in black and white. My cardiologist, the very first visit, did an EKG just to see what was going on. I mean, there was really nothing going on except high cholesterol, but anyway, but it's always, I love my cardiologist. I like having one in my life, especially as we age. Is there a blood marker or other test that quantifies you with pulmonary hypertension?
Yeah, so no. So there's no blood markers that is specific to pulmonary hypertension. The diagnosis of pulmonary hypertension is really made on an invasive right heart catheterization, where we put a catheter inside the right heart to actually measure the blood pressures inside the lungs. An echocardiogram, so an ultrasonogram of the heart, is a good screening test for pulmonary hypertension. And so that's often the first thing we do. And if there's signs on the echocardiogram that may indicate that you have pulmonary hypertension, then we might recommend doing the right heart catheterization. But it's important to remember, pulmonary hypertension, the main symptom of pulmonary hypertension is shortness of breath and dyspnea. So like if you notice that you're walking and you're getting really winded really quickly, that's something to bring up to your doctor, because an echocardiogram is a test that's very, cheap, non-invasive, and can give you a lot of good information to kind of figure out what's going on, especially with patients with MPN that might be at risk of both heart disease and pulmonary hypertension.
So there's a lot of questions here about statins and about preventative use of statins. And I know the jury's out, some people say don't start statins until you absolutely need them. Should this person consider statins? They're 72 with ET and currently take Eliquis. I have normal lipid profile, but calcification and ascending aorta and minimal in the coronary arteries.
Yeah, so I think this is, if this was my patient, the age alone would let me
Yeah.
would have me do a statin. So when we do statins, we calculate something called an ASCVD risk score. Essentially, what's your risk of in 10 years to having a heart attack or stroke? And even when you have normal LDLs, or the LDLs are not that elevated, statins have been shown to reduce the risk of heart attacks and stroke. And especially more so if you do have evidence of calcifications in vascular beds, either in peripheral vascular or coronary arteries. I kind of treat them the same. If you have it in both, even if it's a low amount in one, that to me that screams polyvascular disease. To a cardiologist, that means it's a higher risk. So I think statins in that case would totally be appropriate. Because the effect that statin has is not only on the reduction of LDL, obviously the lower the better, but statins also are thought to have this pleiotropic effect where it reduces inflammation. So atherosclerosis at its core is an inflammatory disorder. And so statins kind of work in both ways of reducing inflammation and also reducing the cholesterol, which kind of, propagates everything.
That's so interesting because I know there are studies about inflammation and MPNs.
Mhm.
And so, it's all relative, isn't it? Is valvular heart disease more prevalent amongst MPN patients?
That is a fantastic question. Again, it's not known. It's actually one of the projects that I'm working on, particularly the valvular heart disease that I think is maybe more common in MPNs, and there is some evidence is aortic stenosis. So it's the hardening of the aortic valve, and that's been shown that the inflammation, like you said, and a lot of the same risk factors for coronary artery disease increase the risk of aortic calcification, aortic valve calcification, and aortic stenosis. There are some studies that suggest maybe patients with MPNs have a higher risk of developing aortic stenosis. As far as the other valvular disease, such as mitral, tricuspid, it's that's much less studied and much less known. But I think aortic stenosis, there may be a signal, but I think that's still kind of early.
The answer to this is, do MPN medications adversely affect the heart?
Yeah. So, as far as, cardiotoxic medications of cancer, that's kind of like what the cardio oncology field is based on. MPNs are this interesting group where I think the MPN itself causes more cardiotoxicity than the treatment. So as far as hydroxyurea, there's really not much evidence that it's cardiotoxic at all. I mean, it's used in both MPNs and things such as sickle cell. And so as far as, hydroxyurea, there's not much evidence. Older medication, anagrelide, has been maybe shown to increase the risk of heart failure and like fluid retention, but it's not used as much. And I would defer to the hematologist of when they would choose one over the other. And then the other is Jakafi, which again, there's not much evidence. There was a meta-analysis that showed that maybe Jakafi reduced blood clots in patients with PV, and we're actually presenting a poster at ASH that suggests that maybe it reduces heart failure in patients with MPNs. But again, it's very there's no like formal like randomized control trials. These are all small retrospective. So, but at least there's no signal that there's increased cardiotoxicity in MPN medications.
That was the next question. What drug do you think, is more beneficial for the heart? Let's see. Can one overdo cardio?
I think you have to just listen to your body. I, you know, I don't think one could overdo cardio unless, you're starting from zero and then you try to run a marathon without training. But I think if you're just, someone that does cardio 4 times a week and, obviously you listen to yourself, you don't overexert yourself, you don't have symptoms of fainting or anything like that. I think it's very hard to overdo it. Obviously, you just have to listen to your body and not overdo it. Make sure that you're stretching, that you're not injuring yourself. So
Another question from a woman, and this question comes up very often about the hematocrit. You know, they said this number for men, this number for women. She said, should it be under 42 or 45?
You're right, there is a difference between women in the guidelines. I put 45 just the easiest number for me to remember in my slides. I actually would ask your hematologist about
Yeah,
that. Yeah.
I think it is between 42 and 45, to be honest, from what I recall. I was told A1C is not the best test for MPN, and fructosamine is better. What are your thoughts?
That's a great question, particularly with PV.
Yeah.
So much like in ET where you have a lot of platelets, and that's why aspirin twice a day. And when I mean twice a day, I mean once in the morning, once in the night, not at the same time, because that kind of, if it's at the same time, kind of defeats the purpose. I think I saw a question about that. So it has to be, at 12 hours apart. But similarly, because A1C is a test that it essentially measures an average on 3 months of how much of your hemoglobin is glycosylated. That in PV might be less sensitive. I think fructosamine is something that that might be better to track over time. That being said, I'm not as familiar with the cutoffs of using fructosamine as a marker, but that is a great point. Yeah.
Mhm. Should all MPN patients have a cardiologist even if they're doing well? Should it be any cardiologist, or should they have one that specializes in blood disorders and cardiology?
That's a great question. As a cardiologist, I might have a conflict of interest and say, of course, everyone needs a cardiologist. But I think the thing, given that the high risk of cardiovascular events, the 1 in 5 patients with MPNs will have a thrombotic event, and heart failure is becoming more and more of known issue in MPNs. I think it is a good idea to because you're higher risk to see a cardiologist, mainly for preventive cardiologies. The best cure is prevention. As far as the type of cardiologist, I think at this point any cardiologist would probably be good. This whole field of cardio-oncology, particularly ones that cardio-oncologists that focus on hematology and stuff. If you can find one, that'd be great. But
Gonna
because it is such a new field, not many cardiologists, go into that. But I think as the years progress, the new graduates become more and more interested in, such as myself. I think there will be more of a cardio-oncology, presence in the country. But right now, I think any cardiologist, would be good.
I 100% agree with that. And I think that the more attention that is paid to what's happening with MPN patients and their cardiovascular systems is so much part of what they need. I'm an ET patient with a JAK2 mutation, and am known to have an extra heartbeat, but with a low heartbeat count. I struggled to get the numbers above 50. I have hypertension and do have a cardiologist. What type of questions should I ask my medical team? Great question.
That's a great question. A heart rate of 50, and if you're not having any symptoms, and the extra heartbeat just could be because your heart rate is so slow. And since you already have a cardiologist, I think, the only thing I would kind of bring up to mind is if there's any symptoms, if you're having shortness of breath, if you notice that if when you walk, you're getting dizzy or lightheaded, that might mean that maybe your heart rate is too slow, and your cardiologist might need to kind of look into that a little bit more. But if you're overall feeling well, I think just following up with your cardiologist should be suffice.
This is an interesting question. I was diagnosed with PV 24 years ago. For the past 10 years, I have been using Jakafi, which has controlled my hemoglobin. My cholesterol profile is unusual as my HDL is low, 27, as well as my LDL, which is 83. My LDL particle number is 2,176. Are statins appropriate?
Yeah, that's interesting. So actually, patients with PV and particularly at myelofibrosis are kind of known to have lower LDL than the general population, and that has to do a lot with the cell turnover. that you have, because LDL and cholesterol is actually one of the building blocks of cell membranes. I think statins, an LDL of 83, especially with the low HDL, still, that still kind of puts you in the higher risk category. Like the LDL is still a little bit, it's not super high, but it's still, a little bit high. It's within the normal limits, but again, there's no such thing as too low of an LDL. And with an HDL also being low, I think that kind of combo, I think, if there's an indication for a statin, I think that it still would be a good idea.
Yeah. Has the cardiovascular risk been stratified according to the patient's mutation, whether they are JAK2, MPL, triple negative?
Yeah, that's a great question. So there are studies, particularly looking at thrombosis, where JAK2 mutations are a slightly higher risk of thrombosis than the other mutations. Particularly, calreticulin tends to be the lowest risk, and the CalR mutations in ET for thrombosis. So there is studies, there is some evidence that JAK2 might be kind of like the worst offender of thrombosis, thrombotic risk.
How do you know if you have any of the non-thrombotic cardiovascular diseases?
So those are not subtle. So I think those, the heart failure and the pulmonary hypertension, if you have any symptoms of shortness of breath, you can't walk as far as you could, because you get winded. You can't lay flat because you get short of breath if you lay flat, or if you wake up in the middle of the night with shortness of breath, or you notice that at night you have to sleep with a lot of pillows underneath your head, because if you lay flat, you can't sleep. You wake up like you're drowning. Those are kind of the symptoms of heart failure and pulmonary hypertension that people may have, that may prompt medical evaluation, and leg swelling as well.
Right, right. And this question came up at our meeting in Asheville with Dr. Messa's group. And should I take my 2 aspirin daily together or separately? And I think the answer, but you can answer, was go ahead.
Yeah, so I think separately, because the whole issue is that the platelet turnover. So if you take it at 2 different times, that's probably when it's most effective. You do it all at once, it kind of defeats the purpose of taking it at different times.
Which is better, a cabbage or a stent after a microcardial infraction?
That's a classic cardiology question. So it really depends on like a lot of factors. So one, I think one of the most important is the patient factor. If the patient's really frail, and like cabbage can be a pretty big surgery where you have to do a sternotomy, and surgeons are great and usually have great results. But the more frail the patient, the more hesitant I am. The other is the anatomy of the myocardial infarction. Where was it? What vessel was involved? Was it and then what vessels weren't involved in the heart attack, but had significant blockages. So normally, and if the patient had diabetes, there's a lot of factors. So that being said, it just really depends on how complex the anatomy of the blockages in the heart, either the ones responsible for the heart attack or the ones that are not responsible but still have significant blockage. How healthy is the patient to undergo a big surgery? And if they have other conditions such as diabetes, patients with diabetes may do better with the cabbage than a stent. Patients with low ejection fractions might be better with the cabbage than with the stent. And patients with either triple vessel or left main disease might be better with the cabbage or a stent. But again, that's very individualized. So I've definitely stented patients that have left main disease, and it's definitely sent patients for cabbage who just have a LAD. So it really depends on the patient. But that's a great question.
This is so fascinating. Just in the last month, my sister had a heart attack, who is very fit, and one of my dearest friends who is extremely fit, male and female, both had heart attacks and have stents. And I think stents are like one of the best things that ever came about. What time of day is best to take a statin?
Yeah, so I think there is some evidence that maybe at night might be better, but I really just tell people whenever they can remember it. The best time of day is the most likely for you to remember to take it. And there might be evidence where, like, maybe at night it's a little bit better, but like those, when you look at a big population, yeah, it's statistically significant, but the effect is really not that big. So I really just recommend just whenever, you remember.
Are there any studies that have insight on any additional complications with your heart if you have an MPN and an autoimmune disease?
That's a great question, because you kind of have like a double hit of the autoimmune disease. There's not many studies that I can recall, but that's a great question.
Can an AV heart block be related to one's MPN?
AV heart block, I think that's a little complicated. Depends on when and how old the patient is and how, severe the AV heart block is. Generally, what we see AV block is in older individuals with a history of heart failure or a history of high blood pressure, because over time the high blood pressure kind of scars the conduction system in the heart. To my knowledge, not necessarily an association with MPN. But it might be just a consequence of age and other cardiac comorbidities.
We have a few more questions and just enough time to get those in. Is the use of the supplement nattokinase a useful addition to one's daily regimen to aid in circulation?
I've actually never heard of that.
Me neither.
I know it's not in the guidelines, and I'm not sure what the evidence is, so I actually don't know. Yeah.
Okay. Let's see. This person is 70 years old. They were diagnosed with ET in 23 through blood work with no thrombotic events, low cholesterol, cardiac calcium test of 0. They take hydroxyurea 4 times a week, daily aspirin, daily iron, and Synthroid for Hashimoto's. I see my GP twice a year for checkup. Do I need to have a yearly checkup with a cardiologist? No doctor has referred me since I am healthy in that area, but with an MPN, should I have? That's a great question. You kind of
So,
answered that earlier, but
yeah. Yeah, I think it's always a good idea. I mean, it seems like your GP's doing a great job from what
yeah.
I'm hearing. And sorry, how old was the patient?
Oops, 70.
70 with a calcium score of 0. That's pretty good. So I
They're
think,
very good.
yeah, I think it's not a bad idea to see a cardiologist at least once a year, just to get a checkup and everything, especially since some of these things can progress a little bit more insidiously, that cardiologist has more time to kind of pick up on. I think your GP does a great job. A lot of things with medicine is, for example, when I see my general cardiology patients in clinic, I want to, help them out with their knee pain and their back pain, and like make sure they're up to date with the colonoscopy. Because all cardiologists are internal medicine trained. But unfortunately, because we get scheduled so many patients, I can only focus on one thing. So I think having another specialist where they can think about the heart health and let the GP just kind of worry about the prevention stuff is a way to kind of work within the bounds of the healthcare system and the constraints, and kind of make sure that you're crossing your T's and dotting your I's.
So in closing, and this was fantastic. I so appreciate you. And for your first webinar with us, it was wonderful. And we hope you come back and possibly join us for some in-person events. But in closing, what information can you impart just in general to our patients that are with us today and that will be watching subsequently? The good news about heart health.
Yeah, I think that one of the good news is, if you're a patient that's watching this webinar, you're already taking a major step of being your own advocate and being involved in your health. And I think that's just, I think, one of the most important ways to kind of improve your health. So I would just commend the patients watching for doing that, and also keep those questions coming, keep asking the experts that you have time to talk to, keep asking your cardiologist, your GPs, your hematologist. I think that the more involved patients are in their health, the more engaged, the better the outcomes. And the MPNs seem scary. There's lots of risks, but there's a lot of things that are also within your control. So I think I think there is a lot of hope.
That is absolutely spot on. And I loved what you said earlier about listening to your body. I mean, we just have to do that. And we know if something's wrong, usually.
Of course, yeah.
So anyway, thank you so very, very much. And to the patients out there, this was recorded and you can watch it again. And we will be in touch with you. Thank you very much.
Thanks for having me. It was a pleasure.
Oops.